it's a great pleasure for me to ask Louca to speak to you about new aspects of urogynecology and the interface with primary care. Onsi and I have known each other for 25 or maybe 30 years, and we've been working together at Northwick Park, where he is the clinical director. He has had a special interest in urogynecology for as long as I can remember, and I'm looking forward to his presentation.
Yeah, thank you, sir. Hello, thank you for inviting me to talk to you today, and thank you for BMI, who have been patient with me. They've been inviting me for the last 4 years, and I didn't have an opportunity to talk to you, but I've got a very short presentation with only a couple of messages, so if we can make a start. Women, have prolapse and incontinence often coexist, and the causes of prolapse and incontinence are more or less the same. And that's why, we try as urogynecologists, that's why we created the specialty of a urogynecologist. Somebody has some gynae experience to deal with a prolapse, and in the meantime is able to deal with most cases of incontinence. Sometimes we have to refer some incontinence patients for some complex problems to urologists, but most cases of prolapse will be treated by a gynecologist. The commonest cause of incontinence is childbirth. Just getting pregnant can put more pressure on the bladder. And the commonest cause of incontinence is stress incontinence, which is caused by childbirth. The second commonest cause of incontinence is surgery, because during surgery, especially even cesarean section, some people think cesarean section is very protective against incontinence, only if done by people who know how to do a cesarean section and been trained maybe in my days. But when I see the registrars now doing cesarean section, they push the bladder quite a long way, and that's denervate the bladder and makes it more likely to have to result in incontinence. When I was a registrar, they told me when you do a cesarean section, don't touch the bladder. But nowadays, people are very aware of the bladder, very conscious that they don't want to injure the bladder. They push it quite a long way, and they do the same with hysterectomies. And I'm sure Sanjeev will tell us there are a lot of denervated bladders which are quite difficult to deal with. Chronic chest conditions, continuous pressure on the bladder cause this, and abdominal masses. You see sometimes people who have not had incontinence, they've had 2 or 3 children in the past, and they go to the GP, say suddenly they develop incontinence. And we have always to be conscious. One of the messages you take today is that whether they have developed something to put pressure on the bladder or not. I've seen a lot of ovarian cancer that just simply patients came with incontinence after they've never had it and developed acute incontinence because there's a big mass pressing on the bladder. So a slight increase in the pressure will result in incontinence. We talk about the prolapse for a few minutes before we go. And prolapse means, the word prolapse in human body means an organ had moved from its normal position. So this organ, if in context of gynecology, could be the bladder, could be the uterus, could be the rectum, could be the top of the vagina, which is the vaginal walls, or could be a hernia of the vaginal walls through which the bowel can come. So these are the organs that come out, and it is important to remember that, like as prolapse described as a hernia, that cutting the prolapsed organ is not the treatment. The treatment of prolapse is either support of the defect or closing the defect. But just simply cutting the prolapsed organ is not the treatment. Because a lot of people think the treatment of prolapse is doing a hysterectomy, and that's only a small part of the operation. If anybody does a hysterectomy, if it's not a urogynecologist, which is what the college recommends, then you find those patients coming with a different prolapse, maybe the bowel, because the defect had not been repaired. And a lot of my colleagues ask me about the degrees of prolapse. That even the textbooks and incontinence societies not agree on the degree, and I always advise people to describe what they see and in what position, because obviously the prolapse is very much affected by gravity, and is a uterus popping out when a patient is walking. That doesn't mean when the patient is lying on her back you see the same thing. But if you would like to remember, first and second and third degree, first is the prolapsed organ still within the introitus. The second is just part of the prolapsed organ just outside the introitus. and the third when the whole of that organ, whether bladder or rectum or uterus, completely outside the introitus. So these are the 3 degrees, but I would like in the referrer, if you can, to describe what you see and in what position. Is a left lateral position, or or patients lying on her back during examination, patients straining or not straining. But if you want to simplify it, first, second, third degree, first within the introitus, second just outside, third the whole organ completely outside the introitus. So when you see the whole uterus outside and you can feel the fundus, that's the third degree. But seeing part of the uterus, seeing a small part of the cervix, that's the second degree. Seeing the cervix within the introitus, although it has come or down already 10 centimeters from its normal position, that is still a first degree. Obviously, we get a lot of letters say this patient has procedentia, and when we look, we just see the cervix at a distance, because in some of the hospital teaching, we say when you see the cervix, that's procedentia, but that's actually only a first degree. And that sometimes it is asymptomatic. Sometimes you find the prolapse because you examine the patient, you came for a different reason. Sometimes just patients complain of feeling a lump or dragging sensation, or having a recurrent UTI because the bladder does not empty completely, or constipation because of the rectum does not empty, or in advanced cases, vaginal ulcers or bleeding. I just would like to tell you that we don't treat the prolapse because it is there. A lot of people are living with prolapse with no problems. If the prolapse is asymptomatic, they do not require treatment. It has to be bothering the patient one way or another. And I have to say, contrary to what you think, the GPs should be treating like 80% of the prolapse. Like they should be treating like 60% of the incontinence, and I will tell you how. So it is that's why you are here. The majority of the cases are not treated by surgery. The prolapse effects on patients get worse with vaginal dryness. And one of the things that GPs can help with is to give estrogen cream. I have a lot of patients that referred with a minor degree of prolapse and with a very dry vagina. We give them Ovestin cream or other estrogen creams, and they feel a lot better because the vaginal skin, which is maybe slightly outside the normal position, gets a lot stronger with some estrogen cream, and their symptoms improve quite a lot. Changing the lifestyle, some patients are constipated and they are not looking after themselves in this respect. Improving constipation reduces the impact of prolapse. I suspect most of you are able to insert a ring pessary. And if you don't know, we welcome a lot of GPs at Norfolk Park. I have a prolapse clinic, and we often have 1 or 2 GP trainees or GPs, and we show them how to introduce a ring pessary. It's not difficult. You just need to see it once or twice. And we have 50 patients in the clinic, and they all have prolapse. And we do 2 clinics a week. So are welcome if you want to ring us. We can accommodate you to come to just see few ring pessaries if you want to work with us. And we actually, the doctors at Norfolk Park don't insert the ring pessary. We have 2 specialist nurses, and they put most of the pessaries. And we tend to discharge them after putting the first one. And as the CCG recommends, we should not see patients for reinserting a ring pessary. So you are welcome to come if you are not doing it already. And if you ask me if there is no ring pessary and you want to insert the first one, how can you judge the size? If you put 2 fingers in the bimanual examination, as I'm sure all of you do bimanual examination, and try to reach the sacral promontory, which is the bony prominence at the end of the vagina, and that will be the distance between the finger at the introitus and the bony prominence is the distance or the size of the ring pessary. So you take your hand out and just measure it on that finger, and that will be the size of the ring pessary you need to consider. You can't put it, obviously, the ring pessary, if it is 80 millimeter, the vagina does not take that size easily. So the nice ones, you can put them in hot water for a minute or so. Even if there is no hot water, put it in just a warm water or just tap water and squeeze it into an H-shaped, and then put it in the H-shaped, and then it will unfold inside. The shelf pessary is less popular we only use the shelf pessary, which is quite bulky, difficult to insert and difficult to take out, and only if all the ring pessaries failed. And the ring pessary needs some vaginal tone, some pelvic muscle tone, because the pelvic muscles are the ones which are going to hold the shelf, any pessary. The shelf pessary doesn't need as much vaginal tone, so it is a mechanical obstruction of the vagina. So you can put a shelf pessary if all the ring pessaries failed in patients who are not well enough to have epidural or general anesthetic. You can do a lot of vaginal hysterectomies and repairs under epidural. So very rare we come across somebody who is not fit enough. I did one operation last week, 94 years old, she's fit enough, and it takes usually half an hour with no complications. So it is, so very few people will need actually to have shelf pessary. As we said, the main aim of the treatment is to repair the defect and remove the prolapsed tissue. Everything, when you remove when you repair the defect can come back again. So sometimes the pelvic floor muscles have been damaged severely, and some patients need tapes or to support the prolapsed part. And this can be done abdominally or laparoscopically or vaginally. So sometimes you have to put a tape and insert the tape, the one end of the tape to the prolapsed part, like the vaginal vault, and the other end either to the sacral spines or ischiospinous ligament or sacral promontory. That's a bit complex operation. We don't need to go through the details. With the incontinence, anything that upset the patient or she feels wet, which is not socially acceptable to her, is incontinence. So patients are different. Some people, 1 or 2 accidents a week would be a problem. Some people can be incontinent a few times a week and they don't have a problem. There are a number of causes. I mean, the fistulas and diverticulums are very rare, but the 2 main types are either stress incontinence or overactive bladder. It's often the symptoms the patient tells you can indicate whether this is an overactive bladder or a stress incontinence, where stress incontinence they lose when they cough or sneeze or laugh or climb the stairs or do exercise or jump on the trampoline or play with the kids. And the overactive bladder is more of waking at night to pass water, going to the toilet very often. As soon as they go home, they just feel they need to rush the toilet. Sometimes they lose water on their way to the toilet. However, the symptoms are not always reliable. And when they come to hospital, if obviously the primary care treatment had not worked, it's essential we do video urodynamics before we offer them surgery to ascertain that type of incontinence. We can't operate. However, we can give them medical treatment before we do any tests. One of the commonest operations for stress incontinence is the insertion of a transobturator tape. It's a very simple operation. Our average operating time is 10 minutes, and 98% of patients go home the same day with quite a high success rate. NICE guideline said any incontinence operation should be 90% successful. We audit our results every 500 operations we look at 2 years plus, and our success rate has been 99%. And it's a very simple operation. We looked at 2,000, we've done quite a lot, but we looked at 2,000 who actually had more than 2 years, and only 2 in 1,000 have voiding difficulties. It's a very small risk. That's a long-term voiding difficulties for which they need intermittent self-catheterization. So it's a very simple operation. There has been no bladder or urethral injuries. There's a different version with TBT, which has a lot more bladder injuries, but like anything else, if you train to do something and you can do it well, you are not going to have complications. So there is no difference in outcomes if you do TBT or TOT, provided you know how to do it. The treatment of overactive bladder is, as Sanjeev was talking about, you have to check how much they drink, how much they pass. So if somebody is drinking 10 cups of tea a day, then they have to check. So it's important to ask them about their drinking habits. Tea, coffee, other caffeines in Coke, Diet Coke, and red wine usually irritate the bladder. Any GP can prescribe anticholinergics before referring to us. I'm not a big fan of oxybutynin, which is maybe more effective in men. We did a number of studies on oxybutynin with intention to see how many patients were taking the tablets 3 months after starting the treatment, because oxybutynin is what's recommended by the National Institute of Cost Effectiveness, which is called NICE. Is really, you have only 1% of patients are still taking the tablets after 3 months. And I think that's a waste of time. If they see the GP and the GP prescribes the treatment, which should be thrown away, because many patients will have dry mouth, palpitations, and sometimes urine retention. There is no point in giving oxybutynin at all, and we don't prescribe it at Nortec Park, although it is in the pharmacy, and we managed to convince the pharmacy not to buy it for gynae patients. But if you prescribe anticholinergics, provided through the tool and VisiCare, are a lot more effective. And I will talk about the medicines just in the last slide. And now we have a new beta-3 adrenoceptor agonist, and that's Bitmega. Our experience with Bitmega is only short, like the last 2 years. And we don't prescribe it as a first line, but we give it after failure of the anticholinergics. Again, NICE said, if you have failure of anticholinergics and Bitmega, we can give Botox or do a nerve stimulation. Botox is very easy. We have not had a single case of urine retention at Nortec Park. They have it. I'm sure Sanjeev will agree with that. It just is we do it as outpatient. We haven't done outpatient at Nortec Park because we don't have a suite, but we do it under local anesthetic and theater. Again, it's just simple injections in the bladder, and it takes less than 5 minutes, and they go home 2 hours later. Once we confirm they can pass urine, they will see a bit of blood in the urine for 2 days because of the injections in the bladder. It doesn't mean a lot, and the retention rate is very, very, very small. I haven't come across one. Yeah. So the GB can actually handle the lifestyle changes and anticholinergics and Bitmega before they refer them to Nortec Park or any urogyne center, and we're quite happy just to perform surgery. So that's the role of primary care. You can assess severity of symptoms, look for pelvic masses, commence treatment over active bladder, and you can insert and replace ring fisters, refer to physio, refer to urogyne clinics. So actually, most of the treatment of urogyne cases can be done in primary care. We are only interested in doing the cases where they require surgery, and we'll do the case studies later. I get sometimes letters from GP, we can't prescribe this medicine, we are not responsible for that. In Harrow, because of these difficulties, and I've been a clinical director for my department for 11 years, we managed to put the budget, the pharmaceutical budget, in one pot. It's not owned by the GPs, it's not owned by the hospital, it's only one pot. However, I still write to the GP, I said, please prescribe this medicine, and tells me it can't come from our pot because they don't know we have one pot. So, and they send me to issue a prescription, which I think is a waste of time for the patient. So, and I'm worried about, one thing happening in medicine, that the government has treated doctors as employees who are no longer have the, or most of us have not had the idea of full care for the patient. And I think we can't work except if we work as a team. So we'd like GPs, community worker, consultants, and managers, hopefully, which I'm not sure will happen, push the same side. Otherwise, patient's care can be affected. Thank you very much.